Good afternoon, everybody. This is Erin with the Department of Medicaid. It is not quite 1 o'clock and we're still clearing out the waiting room, so we'll give it just a moment before we get started.
Okay, thank you, Erin. So Michelle.
Good afternoon.
I'm here.
Good afternoon.
Russ, the waiting room is cleared if you'd like to go ahead and begin. I saw the 4 out of 5 of you.
Who's our fourth? I'm missing one.
My apologies. I saw yourself, Michelle, Lori, I'm missing Elaine, and I'm missing Chris. Sorry.
I see Lori now. I missed her. Hi, Lori. All right. So welcome, everybody. Introductions. This is Russ Rinaldo. I'm the chair of the TAC. I'm the CFO at Owensboro Health. Lori, want to introduce yourself?
Good afternoon. Lori Ritchie Baldwin, and I am the CFO for St. Elizabeth Healthcare.
Elaine?
Hello, I'm Elaine Johnson. I'm the Chief of Payer Administration at UK Healthcare.
Michelle?
Michelle Lawless, and I'm the CFO of MedCenter Health in Bowling Green, Kentucky. Obviously, Kentucky.
Then Chris. I don't know if Chris joined us yet or not. Okay. Chris is missing action, but we've got a quorum. And okay, so do I have a motion to approve the minutes or any comments on the minutes from the previous meeting?
I'll make a motion to approve the minutes.
I'll second.
Okay. Any opposed? All right, motion carries. Let's start with old business. The sepsis work group, I know it got canceled, is with the passage and the signing of the legislation. Are we going to table this meeting? Anybody from DMS?
I'm scrolling. I don't see Justin on, but
Erin,
I can.
just got on. I'm sorry.
Thanks, Leslie.
Late.
No worries.
Can you repeat? I just literally just got on and I couldn't hear very well.
The sepsis work group got canceled, but I was assuming that was because of the legislation that passed and was signed. Just questioning if we're going to table that work group or we need to continue to meet.
Not sure. Honestly, I don't know if I need to answer that today. I'm sorry. The rest of our group is off at a work retreat and driving back as we speak.
Oh, okay. All right. Well, if we can ask that question and get an answer back on that. I think I know the answer, but I just want to confirm.
Erin, is Jonathan on? I'm sorry. I don't mean to keep jumping around. I'm just double checking who we have on today.
Hey, I'm Jennifer Swingle. I'm here with policy, and we will not be having those meetings going forward.
Thank you.
You're welcome.
I thought we might have somebody on.
thank you. Do we have anyone to talk on the NDC issue? I know at the last meeting we asked if we could have a pharmacy here, and I don't know if pharmacy's here.
Sorry, this is Leslie.
I'm not.
Okay,
Sorry,
thank you.
Leslie. You
Thank
beat me
you.
to it. I was scrolling. I don't see anyone from
It might be
pharmacy.
because they were at the retreat and driving back.
Okay.
Russ, I apologize. I was trying to get off mute. The email that I received from Justin to cancel the meeting says we need to permanently cancel sepsis 3 meetings since the law now we use 2.
Okay. Thank you.
You're welcome. And my apologies. I probably should have put that in the meeting cancellation.
And then Aaron,
That's okay.
Sorry, are we looking for somebody from pharmacy? Is that what you said? Sorry, I was having trouble hearing.
I do not
Or
see
someone-
anyone from pharmacy.
Okay.
Okay. I guess we continue to have churn with the NDCs. And so is there someone I can reach out to, or is there someone that we can have for the June meeting?
So Aaron, do you
Someone
want to connect Russ with Fatima? There might
Yes.
be somebody under her that she has working on that.
Yes, ma'am.
Okay. SB 20 issues. I think what I heard last Friday is that we were given a workaround.
Jennifer or anybody else on that can answer that one since Justin's not on?
I believe that would be a under Jeremy Armstrong's area. I can't think of the branch manager's name at the moment. I apologize.
Is it Chelsea?
It's Chelsea oversees MCO contracts.
Okay.
Stephanie
Sorry.
Hodges. Hi, this is
Thank you.
Chelsea.
Thank you,
Stephanie
Chelsea.
Hodges. Yeah, she is the SB 20. She deals with that. Yes.
Thank you, Chelsea.
Justin is joining now.
Oh, thank you.
Okay.
Yeah, everybody's in vehicles, I think, except me.
Okay, I think Justin is on now if you need him. I don't see him pending in the waiting room.
Hey, Justin. We're just going through some of the old business items.
Okay.
We got the message that the sepsis work group's canceled. NDCs, I've asked if they can hook me up or connect me with somebody from the pharmacy that I can invite to the meeting. I think we asked for it last time, but I don't know that there's anybody on. The SB 20 issues, I think what I heard on Friday is that they were working on a workaround that would be suitable for across-the-board adoption. So I still think that's in progress. I understand that correctly? Anybody from the TAC know anything different? All right. The retro authorizations, I know, I think some examples were sent, but we continue to have issues with retro authorizations between some of the MCOs, where the policy doesn't meet what's put in practice, where there's inconsistent. So there's a policy not to get an authorization, but they get denied because they don't have an authorization within the MCO. There's another MCO that says that, that there should have been an authorization because it was assigned, but the hospitals don't know what MCO is assigned until after the fact. So there's some timing issues of when the MCO knows versus when the provider knows. But there continues to be just fights over these retro authorizations and what is required.
Yeah, I was going in and out, Russ. I'm sorry. I don't know if you could hear me or not earlier, but
I can. Yeah.
okay. Yeah, the sepsis work group was canceled, and I know they're working on the Senate Bill 20 issues. Retro authorizations, I think we have. I know some of the MCOs are still having a few issues, and we're working on some individual cases, kind of on a case by case basis. I think the policies are all set in place and corrected. So if you all run into cases where you're having issues, if you'll send those to me, I can send those to the work group to make sure to get those corrected as soon as possible. I think there's some cases out there still that need to be resolved. So if you all could send those to me, we can address those on a case by case basis and make sure that the MCOs get their systems corrected and then all that stuff done that we need to do.
Okay, I appreciate that. Anybody from the TAC have any questions?
I'm sorry, could you repeat that?
I asked if anybody in the TAC had any questions or input, and there was,
Oh, okay,
no,
sorry.
I
no
don't.
response. I think the next one, we got the vendor request for medical records, and I think I still, so we've, Friday we had some meetings with the MCOs. We brought some Optum folks that work on the revenue cycle side for providers to try to inventory the issue, to try to bring some maybe some weight back into Optum to see if they can help with the issue. I know we've sent some examples. I know Lori, you sent one example. Do you want to go through that, or do you want me to go through that one, Lori? Just as a kind of an example of what we're seeing.
Russ, if you want to go through it, I just
Sure. So it was the hospital billed an inpatient encounter, and it was billed to one of the MCOs in December of 23. Through their own internal review process, they sent an updated bill and an updated DRG, which changed the DRG. And then due to the DRG correction, WellCare recovered their payment that they previously made. And then they, at the same time, they issued a denial and asked for complete medical records. And then Optum issues a letter, and that was in January. Then Optum issues a letter in February stating it was a prepayment review and they needed the records. And that came 27 days after the denial was issued from WellCare. They've got a wrong address in their system, and so the people that needed to get the letter didn't get the letter, and because it went to the lockbox, a wrong lockbox that they've said they've asked to have fixed multiple times, and so it's and then it's a back and forth. Where the vendors come back after the fact, after they've sent medical records to WellCare based on the denial that they got. It's just not coordinated, and it's not just WellCare. There are other MCOs, but it's just not coordinated, and it's causing a lot of rework. It's causing delays in payment, delays in resolving the issue, and from our viewpoint, it's an MCO vendor issue. So we're kind of caught in the middle on it, and so it's and that's just one example of a garden variety of what we're seeing over and over from folks across the state.
Yeah, Russ, the only thing I'll add is we can send lots of examples. I know the last meeting we have, the request was send examples. And so that one seemed like a pretty detailed one to capture all the different issues that we're going through. But we see that quite a lot between the MCO and the vendors.
And
Hi,
we,
Russ. This
we
is Aaron
probably,
Meek from Wellcare, Kentucky. I'm sorry to cut you off. I just wanted to make sure that you had sent that example to someone here at Wellcare, and I offer to, if you would like to send it to me as well, I'll run it by both our internal vendor managers and our provider relations staff. I'll put my email in the chat, and you're more than welcome to send it if you haven't already done so.
Okay.
But it's a continual issue, and it's not just with that one example. It's the process before, it's a you get the denial, and then there's 27 days before you get a letter from Optum, and you have to use a specific barcode. So people are sending medical records in twice. The letters aren't getting there. They're not using the same address. There's got to be, and I don't know if we can have WellCare and Optum at the same meeting, or WellCare and anybody else. I mean, I know we have another MCO that uses, and I believe it maybe, I'm not going to say because I want to make sure, but we've got to get folks together, because it's costing everybody money and resources and time and delays in payments. And the reason it's gotten here is because it's been on the calls for so long, and we can't get any resolution. So we're looking for DMS to help push.
Russ, this is Erin. I wanted to mention Raina with our pharmacy team was able to join us.
Okay. All right. We'll circle back to that. Thank you. So, I mean, WellCare folks, can we get a meeting with the Optum folks, with your folks? And
Yes, I'll reach out to our internal vendor managers and also include you on the email to see if we can coordinate a meeting. And I'll also follow up with our staff who regularly attend this meeting to ensure that they're aware of the process so they can pick this up as it goes forward.
I appreciate that. Thank you, Aaron. Anybody, Lori, anything else? Anybody from TAC, anything else on that?
now at this meeting that we're going to set up, is that going to be just for all of us, all hospitals? What's going to be the structure of that? Because I don't have a specific, I can get specific examples. What I hear more from our folks is the sheer volume.
But this particular issue, I think Michelle was specifically about the medical record process.
Right.
Because they're getting folks are sending in medical records, then they're getting another letter saying that they have to send it in with a specific barcode.
Okay,
and those letters are coming, and it becomes this and rework and duplication over and over and over again. And they've asked for a better process, and we've not been able to facilitate that.
Got it. Okay. Well, I'm going to look into the sheer volume of what we have, and then maybe and let me just get some more details, and I'll bring it back to the TAC if that's something I want to add to our for us to discuss.
Okay.
Yeah, Russ, I'll need to do that as well, because I've heard lots of complaints, but like Michelle, it's just been the volume.
Me too.
And not being paid for them.
Right.
Okay.
Like, I mean, volume larger than anything we've ever seen before.
Yes.
So I'm interested in those, Michelle and Elaine, and I think if we categorize those and what you're seeing, right, to that level, then I think we can have a discussion about how we address that.
And this is Lori. I did get an email response from, Kentucky Medicaid to say they were looking into the issue and would do a thorough review. So I know there are folks there looking into it, but I think a meeting would be great.
Okay. I agree. I'm just writing some notes here. Okay. Anything else on the vendor requests? All right. We want to go back up to NDC issues. Sorry, Aaron, you said, who do we have from?
Raina is on with us.
Hi, Raina.
Hi there, good afternoon. I'm on Dr. Ali's team and I'm one of the associate directors with the pharmacy policy team.
We continue to have an issue on our calls with the MCOs about NDCs. One issue is compound drugs that are being denied when an NDC is not assigned or available for that compound drug. I think the other overarching issue is that, I guess as I understand it, there are multiple MCOs that are using multiple NDC listings or compendiums that don't match what DMS has put out. And so it's even though it's a valid NDC, we're getting denials because it's not an NDC that's on that particular MCO's compendium, and then they don't have the same compendium. So as I guess as DMS asking us we would want one source of truth. And I guess I have the question of, do we need to, because we're asking folks to look at different manufacturers in order to get paid for a different MDC for different MCOs, and we got to know the payer of what drug and NDC we're given that in order to get paid. It becomes this unwinnable so the drug's covered, but the NDC is not on the MCO list, maybe on the DMS list.
So I just want to clarify something. I know you mentioned there was a concern with NDC compounded drugs being denied when an NDC is not available. Is this a second concern with NDCs and the HCPCS code combination for the second? Is that what you're referencing? I just want to make sure I understand your concern.
Excuse me. As I understand it, it's a compound drug that doesn't have an NDC, but they're denying it because they require an NDC.
So the concern would be, this is on the medical benefit where they would be billing are they billing the different ingredients, the NDCs under, and this is for the medical benefit or the pharmacy benefit? I just want to make sure.
This would be hospital bills.
Okay.
Medical bills.
Outpatient. So we'll have to take this back and discuss this a little bit internally. DMS has provided guidance to the MCOs for sources of truth using RJ Health, CMS as well. If you have examples that you would like DMS to further investigate, please send those over to us in an email. We would be happy to take a closer look at those.
I'd love to do that. That'd be great.
Okay.
Can you put your email in the chat?
Yes, I will include my email and Dr. Ali's as well, just to keep her in the loop. And
then after we send the examples, if I'm more than happy to have a further discussion before the next TAC so that I can understand better. That would be great if you guys would be willing to do that.
Sure. I will reach out to Dr. Ali and keep her in the loop. And if you can send over those examples, we will further look at those. Thank you.
Okay.
And if you
Anybody
don't,
else from that?
yeah, this is Greg from UHC. I think this topic is interesting, and it's one that I think we all agree on of having a single source of truth to where we are all validating against the same source. So I know that historically, or previously, we had talked about aligning to a single source of truth that MedImpact uses for their validation and publishes. And we were aligned to doing the IT work necessary to get to that point, and moving away from our internally procured vendor. However, we've learned that that source of truth is going to remain proprietary, meaning it's not going to be shared or published publicly. And so that makes it really difficult for us all to align on the way to validate these claims. So as one of the MCOs, we would support a more unified source of truth for this, and we're willing to do the work to implement that into our system. What we're trying to do now is validate our source of truth and make sure it's fully inclusive of everything that the state or that MedImpact might be publishing, and we've done that work. And so we believe that our records are more inclusive and would allow more claims to pay, but we are in support of a single source of truth like you are.
Thank you for that feedback. I will take that back to our team.
Thanks, Greg.
This is Fatima with DMS Pharmacy Director here. So Greg, I heard you mention that you are willing to align. However, we did send out notification that the source of truth was the CMS and Palmetto file, which to my understanding, both of those are public. And, I think if, we did give MCOs the opportunity to align with that source of truth. So I'm not sure where the disconnect is at this point.
Yeah, so Don Jones is on this call as well. So Don, would you mind to explain a little bit about the disconnect? You might be on mute, Don.
Sorry about that. I always forget I'm double muted on these Zoom meetings.
You're good.
Anyway, so there was a meeting between all the MCOs and MedImpact and Gainwell, and I'm pretty sure DMS was there too. But at that meeting, it was talked about how the Palmetto and the CMS files are just being used as a foundation for what is eventually going to develop into another proprietary file that MedImpact will be using that will not be getting shared with the MCOs. So the Palmetto and the CMS files are public, but that's just a foundation for what will eventually be another proprietary file that will eventually end up as out of alignment.
So I can check on the proprietary nature. My understanding is that it wouldn't be considered proprietary. That was not our goal. I'll double check and just make sure that what MedImpact conveyed, is everyone's understanding.
Okay.
But if that's the disconnect, then we'll certainly double check on that.
Yeah, absolutely. Because I just wanted to say our original intent was to just align with the Palmetto and CMS files, but we found our source of truth was generally a lot more robust. And then when we learned that these are just the foundation for a proprietary file, that's why we went the direction we did.
Thanks for being the man with all the details, Don. I appreciate it.
Sure.
Anybody else in the TAC or in the group? So we'll certainly send some examples. I appreciate this discussion. It's always positive to have discussion and willingness to work towards something that works for everybody. So we will get those examples and continue on. All right. All right, emergency department policies. So we'll continue to see issues. I think we sent examples, but I'm not 100% sure that I couldn't find confirmation of that. And this goes back, I guess. So we've got several MCOs that are using a piece of software, as I understand it, to look at emergency room visits, and they will downgrade visits. So if a hospital bills a level 4 and the software says it should be a level 3, they will put in a denial and either reduce payment or not pay it. And the problem I think that I'm having is that, number one, there's not a reason for the denial, so we don't understand. There's no letter that comes back. There's no reason given. So you're guessing at that point. There's no algorithm that everyone can understand what the MCO is including and what level or why. And there's no human looking at it to say, okay, what else was going on with this patient, looking at that medical record. Again, it's an AI algorithm based, and there's not up coding. There's no well, this was a 2 and it should be a 3. Everything's specifically down denials, but there's no way to appeal it. There's no way to dispute it. There's no way, because there's no reason. There's no letter. The hospital has nothing to go on for denial. And it comes through an agreement. It's automatic, and so it's a problem, because we should have the ability to appeal and take it through the appeal mechanisms, but not knowing the reason, you can't appeal it. So it's come up here because we can't get movement. We can't even have discussions on what it should be and how it should work. But we're looking at DMS to push or facilitate or discuss with us in the MCOs on how we resolve this.
Would you mind if I just ask some clarifying questions on this? Because this hasn't hit my radar yet. Is this problems that you're experiencing with the MCOs in general?
So it's the ones that are using the Optum Analyzer in particular. So that would be UHC, that would be WellCare, and I don't know, and there may be one more, but that's in particular, right? So the Optum Analyzer, so I've gotten reports that you've got folks that are using the Optum Analyzer, but then they're getting back something different. So nobody understands the algorithm that's in the Optum Analyzer and how it works, right? Or what the criteria is being applied to the downgrade. Again, there's no reason, right? It comes through, again, on a remit. And I'm being told in the chat that Humana uses the analyzer as well, but there's no reason. So if you're saying that it was not a 4 that I billed and it's a 3, why?
Okay,
is what I want to know, because if I know why, I can appeal it and I can try to fight it. I mean, but there's a lot to unpack in this, right? There's some, there has to be ethical AI, right? If it's only down coding and not up coding at all, that's a problem, right? If it's not looking at, if it's looking for something that, and it doesn't have it in it, and versus looking at, why the patient came there, what resources were used, what's going on with the patient, the conditions of the patient. I mean, there's a lot of things to unpack, but my biggest concern is that I've got an automated denial that's coming through on a remit from a software program, and no one's touching it, no one's writing me a letter, no one's saying this is why, and I've got a payment reduction, and I can't argue it, I can't fight it because I don't know the reason.
Right.
Got it.
So it's not a reasonable process because
So
I
you,
can't, I can't do anything about it at that point.
so you are getting appeal rights, but you don't know how to address the appeal because you don't know why it
Well,
was denied.
I'm not getting a denial letter. I'm getting something on a remit, and there's no reason code, right? It's just I'm going to reduce this level, right? It's not a pre-authorization denial where I say I got no pre-authorization. I got to have an authorization code, right? I know how to fix
Yeah.
that.
Yeah.
This is I'm gonna reduce your level, Russ, but there's no reason because you can't give me a reason because it's a medical denial, right? You're saying that this didn't meet this level for a medical reason or a lack of something, but you can't put that in a remit. It's not possible. So you're going to have a medically complex denial. You have to have a letter that goes back to the provider that says this is why, so the provider can
Yeah.
look at the record and either agree with you, or dispute it. But we've got to have that. I mean, it's like a DRG. You can't change a DRG to say we expect when you have a DRG change or a diagnosis change, we expect someone to look at it. We expect the doctor to look at it if it's a medical necessity piece. But we expect the coder to look at it if it's elsewhere. But we expect a reason why, and we get pretty detailed reasons on those type of reviews. This
Right.
one, we don't.
Okay. So I'm glad you clarified that. So this is not DRG reductions. This has to do
It's
with,
not. This is emergency room specific. So emergency
okay.
department business, and it's leveling denial
Yeah.
from one level to another, but it's always a down code.
Sure.
There's never any okay, we're going to give you more, we're going to up code it.
Got it.
And it's how it's coming back and you know, the way it's coming back and then with no reason.
Okay.
It's an agreement. It's a remittance advice, and it's
Yeah.
just a change. So
Yeah. So it's something that I want to get more educated about myself. A person like Don is on this call. He's more educated than I am on it. But I'd like to have a meeting to better understand what's happening with it next week internally. And then maybe by next TAC meeting, I know that we reduced the frequency of these meetings. Is this a every other month meeting
it
now?
is. We have our next one's in June.
Okay.
And I think Greg, that there are enough folks that, I mean, this, we have the MCO meetings every 2 weeks with the hospital association.
Yeah. Yeah.
Hospital. I think this would, if you find something or you want to discuss it, it is on that list, and I think we can have those discussions there, or even I'm willing to facilitate an off cycle discussion to give you more examples or kind of what we're seeing on it.
The one thing that would be really helpful to me and Dawn is to get a couple sample remits where this is happening so that we can look into the claim specifically and find out when that reduction is triggered, what other communication and appeal rights are offered to you. It is my expectation that you should be notified about the reason for the downgrade. You should have the medical necessity information or the medical rationale for that. And that you should have an opportunity to appeal that decision. So I want to look into it further. I'm going to get a meeting set up internally next week. If you could get us some remit examples, I'll put my email in the chat. That would be really helpful.
Thank you, Greg. And I think we've got 2 other MCOs. I'd asked the same question of WellCare and Humana, and then the overarching question. The overarching question is for DMS is what's the expectation on this type of denial and what is given by the MCO to the provider, because again this is not something from my view, and I think from others' view, that is cut and dry. It's not an authorization's missing, where you can, from a remit, you can understand what the denial code means and how to have it or not have it. This is more of a, they're looking at it and saying this medically didn't meet a level 4, this medically met a level 3, and again, from the provider perspective, I have to have more to be able to address it.
Well, we would expect for you to treat patients and bill for that, not read our minds. So with that understanding, I can totally understand where you're coming from. So I'll look into it for us, but being so connected to Optum, I'm sure the same answers will apply. So I'm happy to take this on and report back to you.
Okay. Thank you, Greg.
Yes, sir.
Anybody from DMS have anything on any input? Want us to wait and see how this plays out with that, with Greg, UHC? Okay.
No, I don't. I think we'll see, see what how it goes with the meeting between you and the MCOs on that front, and then maybe report back to us how that goes.
Okay. Anybody else from the TAC have anything on this one?
Nothing more than what you've already said.
Yeah.
Agree.
Me either.
All right.
We just have lots and lots of these.
Yeah, we do have lots of these. I know it's not a small issue for anybody.
We'll get y'all more information.
And the other thing I think, Greg, is that we can't, if I can't fix it, right? So it's going to be like that forever. Even if I would agree with the rationale with it, I can't fix it because my process is what my process is, and I can't change something that I don't know how to change either. So that's the other edge of that sword. All right, incarceration issues. We had a really good meeting. We had a really good meeting with a bunch of folks on incarceration issues. I am very appreciative of the coordination of that and the scheduling of that because we got some answers to our questions. I think I know that the Hospital Association, we sent out a basic summary of that and what some of the issues that were answered. We're going to continue to do that work and meet again and maybe work on an FAQ with the Department of Corrections, and so that we can have some clarification and give some folks some education. We've talked about educating some of the jails and the counties on their responsibilities as well. But it was a very well-attended and productive discussion that I appreciate very much.
Russ, this is Leslie. We're going to continue to work on that for you. I think we recently received, if you've not received it already, we'll get it to you. You had some questions about the Interstate Compact research, and we've got that for you, I believe, now. And then also, like you said, we're working on the FAQ, but as we continue to integrate in Kentucky, I really see that this is an opportunity for DOC and DMS to work together to get you some answers and to address things that are going on across Kentucky that, for no lack of a better reason, has kind of just morphed and become a historical thought process with new folks coming in and old folks in history leaving. So we're going to work on that. It's a good opportunity for us to work on that in partnership with you. For us to address it as well. We've got a re-entry waiver that's coming forth, and we want everything to run as smoothly as possible as we can for those folks that are in the community. So anyway, more to come on that very soon.
Leslie, thank you so much. It was I appreciate that. Very, very good, and I'm very grateful. Thank you. Anybody else from the TAC?
Not for me. I thought the email was really detailed and helpful.
Yeah, we had a really good discussion. Everybody participated, and it was really good. So, all right, IOP. new business. So I think this has continued to be a challenge for hospitals and providers that have the intensive outpatient mental health service. It is the requirements that we and the struggles that the providers have with some of the MCOs. I think it's there's requirements for sessions to be counted within a 7-day period. Some MCOs, as I understand it, are processing it on a calendar week, not a 7 days. So it's not a calendar week; it's a 7-day period. The number of we need a process to find the number of visits. We don't know how many visits a patient may have after so many sessions. MCOs are denying. We've requested policies for obtaining additional days of service. So there's a limitation of 32 sessions, even though that is from the hospital's folks is not consistent with what the coverage should be or is under Medicaid. It is. We continue to have a churn of issues, and I guess I'm looking for DMS to identify someone that I can talk to and bring some of these concerns to on the mental health side, to see if we can have discussions and get to a common understanding or a common standard practice. And I'm probably not doing it justice. Anybody else from the TAC or the group that wants to weigh in, please do so.
Russ, we have just began our IOP program. I think it's been in operation for about a month. So we're babies to the program. One thing I know we've had concern about is in regards to what if a patient is sick, something comes up that they can't make their appointment. Are we just unable to bill for that week? Or what do we do in those cases? And I know those are things that we need to find out on our own, but didn't know if that was an issue or not.
And I'll clarify the other two issues as well. So what I understand is Humana is recouping claims because it doesn't recognize a rolling week and only a calendar week. Also, and so the providers have asked if DMS can help in this situation. Also, there's an ask to reconfirm prior auth is not required for behavioral health services. And then Passport has put in a benefit limit of 32 visits for IOP. And the providers have concerns because they view this as an inappropriate benefit limit. It's a reduction of benefits that are otherwise available under fee-for-service.
Yeah, Russ, this is Justin. We actually have a meeting about this next week, and I think we're going to come up with some guidance, and we may call some other people in and talk to the MCOs as well before, but we're going to issue some type of guidance for these issues after next week.
Okay. All right. I appreciate that, Justin. If you need anything from me or you need someone from our side to the hospitals to attend that can speak to it, I definitely have those folks that would be willing to attend as well. Okay. Any other general, other items or general discussion? Anybody from the TAC have anything else?
No, I'm good.
Okay. Don't have any recommendations. I'll represent at the MAC meeting. Our next meeting is June 25th, 2024. And barring no other issues, we will stand adjourned. Thank you, everybody, for your time today. I appreciate it.
Thank you.